Good morning to everyone. I'd like to thank you for being part of this session. I am Giuseppe Esposito, and I'll be introducing the speakers. Again, I'd like to thank you for being part of the session on neuroendocrine tumors. This session is hosted, of course, by the Ruesch Center for the Cure of the Gastrointestinal Cancers. So I'd like to thank the Ruesch Center for the opportunity for once again to bring a focus on the neuroendocrine tumor, on the approach to the cancer and to a treatment. This session is co-sponsored by the Society of Nuclear Medicine and Molecular Imaging. And I would like to spend a few words on the Society of Nuclear Medicine. The Society of Nuclear Medicine and Molecular Imaging is a non-profit scientific and professional organization that promotes the science, the technology, the practical application of nuclear medicine and molecular imaging. The Society of Nuclear Medicine and Molecular Imaging strives to be the leader in advancing, optimizing molecular imaging with the ultimate goal, of course, to improve human health. The Society of Nuclear Medicine has over 15,000 members worldwide and represents, therefore, the nuclear medicine and molecular imaging professionals, all of whom are committed to the advancement of the field. In some of the most important advancements in the diagnosis and treatment of the neuroendocrine tumors in the last few years are really due to the work of several nuclear medicine scientists, radiochemists, physicists, technologists, physicians, and generally speaking, to advocates of the field of nuclear medicine. For example, PET imaging and treatment with radiopharmaceuticals, radionuclide treatments, or PRRT, also known in this way. These PET imaging and radiopharmaceuticals treatments that target the neuroendocrine tumors, they will be discussed in this session. So these are the results of the work of the worldwide community of practitioners in the field of nuclear medicine. And particularly for this session, I would like to thank the Committee on Outreach, which specifically supports this session of the Society of Nuclear Medicine. And the goals of the Committee on Outreach for the Society of Nuclear Medicine is to ensure that the patients in the medical community recognize, of course, the value of the nuclear medicine and molecular imaging of radionuclide therapies. It focuses on promoting nuclear medicine and positioning again the Society of Nuclear Medicine as a worldwide leader in molecular imaging of radionuclide therapy. So the particular goals of the Committee on Outreach or outreach efforts of the Society of Nuclear Medicine are, of course, to increase the number of patients and advocate for the support and the value of the radiopharmaceuticals, and particularly for the neuroendocrine tumors. This, of course, is very, very important because, as I've said before, some of the major advancements in the diagnosis and treatment of the neuroendocrine tumors has been, again, because of the efforts of the community of nuclear medicine practitioners. So increase the awareness among physicians or patients of these new radiopharmaceuticals, improve the collaboration with other medical societies, and increase the awareness of nuclear medicine in the imaging community. So with all of this, again, introduction, again, thanking the Ruesch Cancer for the treatment of gastrointestinal cancers. And after thanking the Society of Nuclear Medicine and Molecular Imaging for the support for this session, I'd like to spend a few words again on the speakers that we have the honor and privilege to have today. Of course, I will be starting with just an overview on the imaging possibilities. What is the role of imaging in the neuroendocrine, in the treatment and care of neuroendocrine tumors? But then we will have a surgeon, Dr. Eric Liu, who will be discussing the surgical approaches for the treatment of neuroendocrine tumors. Then we will have Dr. Emil Cohen, who is an interventional radiologist, who will tell us about liver-directed treatment. in the care of patients with neuroendocrine tumors. And that's a very important part of the treatment of patients with neuroendocrine tumors. And then last, we will have Dr. Strasberg, Jonathan Strasberg, who will tell us about systemic treatments for neuroendocrine tumors, a combined approach, a general approach on systemic treatment. So it will be PRRT, meaning radionuclide treatments or chemotherapy or other agents there for the treatment of the cancers. Of course, at the end of each presentations, we will have the opportunity to see questions that come from the audience and to respond to, obviously, to those questions. So we'll have a few minutes at the end of each presentation. So again, I would like, again, to thank all of you for being part of this. I will, we have a few minutes still for this part, for the introduction, but I would like to start with the first presentation. Again, I'm Giuseppe Esposito. I work at the Georgetown University Hospital. I am a nuclear medicine physician, the chief of nuclear medicine at the Georgetown University Hospital, and I've been involved in the imaging and the treatment of patients with neuroendocrine tumors now for quite a few years. We heard from the very beginning of after the approval of a new PET imaging and new treatments for neuroendocrine tumors. We were early adopters of this, and we have treated several patients with the neuroendocrine tumors. I think it's been a great experience seeing how the improvement on imaging modalities and the treatment of a patient with neuroendocrine tumors really could make a difference in the approach and the treatment for these cancers and in the life of patients with the neuroendocrine tumors. So I would like to start with my presentation. Again, the title of my presentation is Role of Imaging in the Evaluation of Neuroendocrine Tumors. This is my disclosure for conflict of interest. And I would like to give first an overview of what are the imaging tools in the neuroendocrine tumors. As you can see on the left side, we have a CT and MRI. CT and MRI are always, of course, the mainstay, the first imaging evaluations that we do in the patients that may have symptoms or presentation that are suspected to have a neuroendocrine tumor. So even in patients that are not suspected to have a neuroendocrine tumors, that's how obviously we most of the times diagnose a neuroendocrine tumor. Whether because patients had some symptoms, abdominal pain, or symptoms of obstructions, of course, the first imaging modalities, the first way we're going to assess these patients is by doing an CT or sometimes an MRI. And that's important because obviously CT and MRI evaluate the structure, the size, the characteristics of the tumors, and of course, identify the tumors to begin with. So and this is how we call anatomical characterization of the tumor. So see where the tumor is, what is the relationship of the tumor with other structures, and of course, that's important for surgical planning. Into overall initial staging of the disease and also in the follow-up restaging of the tumors after, during treatment. Of course, CT or MRI are always going to be there and going to be often the first imaging modality that we're going to use. Then on the right-hand side of the slide, again, these are what we call the more molecular or functional imaging modalities. And mostly these days it is PET imaging. And PET imaging can be with DOTA or DOTA compounds. It used to be still available, but less and less is imaging with the SPECT imaging with octreotide. And all these, both the PET-CT and SPECT-CT, they target the somatostatin receptors. Somatostatin receptors, of course, expressed on the neuroendocrine tumors. And so that gives us the opportunity to, of course, identify the tumor, stage the tumor, but also characterize the biology of the neuroendocrine tumors, because not all the tumors, the neuroendocrine tumors, will express the somatostatin receptors, and the vast majority will. But some of them have different biological characteristics, and so the somatostatin receptors will not be as expressed in some tumors. And then that's the case where we would probably use FDG PET-CT imaging. But because of PET-CT assesses the presence of somatostatin receptors in the tumors, then this can be the target for treatment like PRRT, radionuclide treatment that target these same receptors, the somatostatin receptors. And so this DOTA PET-CT imaging is of value for the initial staging, biological characterization, and see if these tumors can be targeted for treatment. FDG PET-CT is, of course, the counterpart of the PET imaging with DOTA compounds. FDG is a glucose analog, so we are going to measure with the FDG PET-CT the glucose metabolic activity. So if the tumor has changed its structure and it does not express as many somatostatin receptors, but usually when the tumor is more aggressive, then they tend to have a higher metabolic rate, high glucose metabolic activity, and so FDG PET will be probably a better imaging modality in this point. So the overall goal imaging of neuroendocrine tumors, then I would divide it in initial evaluation staging. So whether to assess whether there is tumor and how many tumors there are, if there is metastatic disease, we can assess the overall tumor burden, see how much disease is in the body. And again, as I said, biological characterization of the tumor. And we can kind of see in vivo, so by imaging what is assessed, so estimate what is the pathology in a way, so what is the tumor aggressiveness, what is the tumor heterogeneity. So starting with the presence of multifocal metastatic disease, or anyhow assessment where the disease is, we can, again, as I said, we would typically start with CT or MRI. The acquisition CT MRI need to be kind of typical targeted acquisition for the neuroendocrine tumors, usually multi-phase contrast imaging. And you can see here, this was a nice review of different findings by of neuroendocrine tumors, specifically here in carcinoma tumor. But you can see here on the left side, there's a CT, and you can see the several lesions, contrast enhancing lesions that we see and we have it in the liver. So CT and MRI here, you can see here, this is a view of the liver. This is a tumoral mass outside the liver. So obviously, CT and MRI are very, very important initial imaging modality most of the times to characterize the tumor, see where the tumor is, see how many lesions there are, and the relationship with structures. That's, again, very important in planning surgery. This is another example still from the same publication where you can see a small enhancing tumor here in the small bowel. And this is another case, and this is a patient that presented with abdominal pain and symptoms of bowel obstructions. And this is now a typical presentation of some of the patients with neuroendocrine tumors, where you can see in this patient multiple lesions. And we also can see an area of the small bowel here that has a stricture, and probably that is the cause of patient symptoms. In addition, we can see some involvement of lymph node involvement here in the abdomen. So again, very, very important initial assessment. But if we, this was a study was published a few years back by the NIH, but is the role of CT and MRI is very, very important. But the changes that we've had in the advancements that we have in the imaging is, again, been particularly important with the adoption of DOTA PET-CT or DOTA PET-CT compounds, because you can see here whether it's tumors in the pancreas or tumors in the abdomen, or what is metastatic disease in the liver and the bones, or lymph nodes in the mediastinum. You can see how the ability to detect the disease by DOTA PET-CT is greater than what we used to be the octreotide SPECT-CT imaging we were using before the adoption of PET-CT agents in comparison to CT MRI. So you can see how the total number in these patients, where there were a total of almost 900 lesions throughout the different patients, PET-CT was able to detect 95% of these, as opposed to about 45% of these lesions seen by CT or MRI. So PET-CT was able to identify almost twice as many lesions as CT or MRI, and definitely more compared with 3 times what was found with occultized SPECT-CT. Of course, the only area where the PET-CT and CT-MRI have a similar, particularly CT have a similar yield, diagnostic yield, is in the lungs, where the high resolution of CT is very, very important compared to the PET. So overall, I would say that's what the change that has been brought by the adoption of PET-CT, is a higher sensitivity, higher ability, higher diagnostic accuracy to identify the lesions. So these are some examples here from our institution. Multifocal small bowel disease plus lymph node metastasis in this patient. So you can see in the different images, there are several areas in the bowel. This is multifocal disease, and then there's a lymph node that's present here. So that gives us a good staging, very accurate staging for the disease in the beginning. So that's very important for surgical planning. This was one case we had. It was a patient that was incidentally found to have a lesion on MRI here in the meninges. The diagnosis was a possible neuroendocrine tumor. So we did a PET, and you can see the lesion here. And we didn't know where the tumor was, where the tumor originated, but only by PET-CT in the abdomen, we can see a very small focus of activity in the pancreas, was not seen by other imaging modalities. And the patient then had endoscopic directed biopsy of this lesion, and we found that, again, confirmed that this was a primary tumor and this was metastasis. So very accurate initial staging. Obviously, the higher accuracy gives us an advantage in overall tumor burden, the estimation, assessment of overall tumor burden. Again, very important to assess the disease, to begin and see what is patient prognosis as well. This is a study was led by Dr. Strasberg, and they looked further into the different patients that were they were treated with PRRT, and you can see that there is obviously there is an advantage of treating with PRRT versus the octreotide treatment, but particularly looking into a little bit more in a patient that had the treatment with PRRT, the presence of larger liver lesions seem to overall carry a worse response compared to patients who had small liver lesions. So this is one particular factor that we take in consideration, and we can assess with imaging and with PET imaging. For example, these are 2 examples I wanted to show. This is a patient with multiple small liver metastases. These multiple liver metastases you can see here in the liver, and you can see also here in this fused axial image. And these are several, but there's more overall small liver metastases. And the study that I showed you earlier in the earlier slide, again, it was kind of a cutoff of 3 centimeter lesion size for less optimal response to treatment with PRRT. But these lesions are all less than 3 centimeters, so that we could infer that the response to PRRT, for example, so radionuclide treatments will be better in these patients that have smaller lesions, as compared, for example, to this patient where has a very large or larger lesion in the liver here, and it has an additional smaller lesion here, and possibly metastatic lesion in the femur. So what PET tells us in this patient, for example, is that there is a larger lesion. And not only that, but tells us a little bit about the heterogeneity of the lesions. We have one lesion that has, or at least part of this lesion, and has high expression of the somatostatin receptors. So that's a DOTA PET. And then a part, or maybe a second lesion here, that is larger and has overall a little bit less expression on the somatostatin receptor. This is very important for planning for treatment or planning for treatment with the PRRT, because again, it is possible this lesion or this parts of lesion have lower activity, would not be reached as much by the treatment compared to these higher activity lesions here. So moderate heterogeneous disease, but also larger lesions that we see in the liver. And obviously in a multidisciplinary approach to neuroendocrine tumors, this is a lesion that potentially can be targeted with the liver-directed treatments, embolizations and so forth, already embolizations. Again, so that all towards a targeted approach to the treatment of neuroendocrine tumors. I spent a few words on the biological characterization of tumors. That's what I want to do here in this next slide. So we have here a case of a patient. This is a daughter PET-CT, a daughter PET-CT where you can see that there are several, hopefully you can see here, there's several small liver lesions here in the liver. If we do the FDG PET, we can see that these lesions do not have FDG uptake. And this is different. This is a patient that does not have a lot of expression of the somatostatin receptors in these liver lesions, but has high the FDG positive lesions here in the liver. So two different tumors, really, two different biologies. One is expressing somatostatin receptors. In this case, it's not expressing somatostatin receptor, but has high glucose activity, glucose metabolic activity. And usually what we see is that the lower grade tumors, less aggressive tumors, tend to have higher expression of the somatostatin receptors, so will be positive on the PET, while the more aggressive, higher grade tumors that you can see here, they're the ones that have higher mitotic rate, a higher Ki-67, they tend to be positive on FDG PET, but negative on the DOTA PET. And so again, that's because the more aggressive tumors tend to lose the expression of the somatostatin receptors, and are more aggressive and so have higher glucose metabolic activity. So again, just to summarize, in assessing biological characterization of neuroendocrine tumors, again, degree of uptake of the dotted PET-CT correlates with the expression of the somatostatin receptors 2 and 5, higher expression in lower grade tumors and lower expression in lower grade tumors. So if there is expression of the somatostatin receptor, obviously these can be targeted by PRRT. If there is no much expression on the somatostatin receptors, PRRT then would not be an option. And again, the higher FDG uptake is seen typically in the G3 higher grade tumors. This was one of the studies that's shown that just that. So we can see that how the higher grade tumors in patients have had both DOTA-TATE and FDG PET imaging. So the higher grade neuroendocrine tumors, only very few of them were positive on DOTA-TATE PET-CT, and many more were positive on FDG. But if we go to the lower grade neuroendocrine tumors, again, the majority of them, or almost all of them, essentially they were positive on DOTA-TATE PET, so expressed somatostatin receptors, while really none of them was positive on FDG PET, again indicating lower grade tumors with high expression of somatostatin receptors, but low metabolic activity. And also this is just absolute values and measures of FDG activity, the typical SUV values. And again, we can see how the SUV was typically higher for DOTA-TATE PET for the lower grade tumors, as opposed to the higher grade tumors where the DOTA-TATE uptake is less. And again, same study, you can see how the number of lesions they were, of course, in different patients, the tumor can be quite heterogeneous, and some lesion may express DOTA-TATE, the somatostatin receptor, some may be positive on FDG. It is possible, but in general, you can see how in a high-grade neuroendocrine tumors, so only a few lesions were positive on DOTA-TATE, and the vast majority were positive on FDG PET, as you can see here. So again, overall, a characterization of the biology of the tumor, not only for the different patient, but even sometimes within a single patient. Why is that important? It's important for the outcome of the patients, for prognosis of patients. It's important because, as you can see here, when FDG PET is positive, prognosis, so the overall survival, progression-free survival of the patients is worse when there are lesions that are FDG PET positive. And it's better if there are no lesions that are FDG PET positive. Again, characterization of the tumor, characterization of the aggressiveness of the tumor. This is one case that we had at Georgetown, again, an unfortunate case. This patient would initially have an FDG PET because the true diagnosis of the tumor, the pathology was not available or was inconclusive. So the patient had an FDG PET, and we saw a few lesions that were positive on PET, but then the final pathology told us that it was a neuroendocrine tumor. And so the dot-of the PET was performed, and you can see how a lot more lesions are seen by dot-of-the PET in this patient, including some lesions, again, many not seen on FDG PET. However, unfortunately, this tumor had some components of high grade, and in the end, that's what happened. In this patient here, you can see some bone lesions which are initially were a lot more apparent on dot-of-the PET than on FDG PET. But then, unfortunately, the tumor changed biologically, and the higher aggressive portion of the tumor took over. And this is an FDG PET again, and you can see the difference between here and here. So the liver lesions are now all FDG positive, and a lot more widespread presence of the tumor in the liver. So again, this is to characterize the biology of the tumor, and you can see when this happens, for this patient, when we had a sudden worsening of the lesions, sudden increase in size of all these lesions, then we suspected that the tumor had changed its biology. So at this point, it made sense to do an FDG PET to confirm that. Again, those lesions were more aggressive and higher glucose metabolic activity. So in among the goals of important goals of imaging neuroendocrine tumors, again, as I said, is the confirmation of the presence of the target of the treatment. And that's what we've seen throughout all these cases. Again, patients that have a dot-of-the PET positive scan, again, they would be eligible for PRRT. Those that do not express the somatostatin receptors at per PET, obviously they're not amenable to PRRT because it would not be effective. And a potential role of PET would be to predict the first-line response, the response to first-line treatment with just octreotide. Again, in particular in non-functional tumors, that's a possible indication for dot-of-the PET CT imaging. But again, as I said, particularly assess the eligibility for PRRT. Again, we have our tracers for PET imaging or DOTA compound. These days we have several options with targeting two different radioactive nuclides, gallium-68 or copper-64, and these are the imaging agents. If we switch the radioactivity associated with the DOTA, again, if we do the lutetium-177, of course, that's a treatment. So that's why we use a PET to see if the target, which is the same because the molecule is the same, the DOTA, again, so we can see with PET the expression, verify expression of the somatostatin receptors, and then target those receptors, those cells that express the somatostatin receptor with lutetium-177, which is the therapeutic compound. Again, this one case, these are two cases where we use PET to assess whether the patients have can benefit from the PRRT. This is a patient had mostly predominant bone metastasis, and which you can see here. So these are only some of the bone metastases that we're seeing, for example, on CT. And these two bone metastases have a little bit lower activity. And you can see here, there's two lesions. One is here on in the spine. This is CT. And these are diffuse PET CT images. So you can see that really this lesion does not have much activity on PET. So really no expression, almost no expression on the somatostatin receptor. This lesion here, which you can see here in a rib, has a little bit of higher expression of somatostatin receptor. So this is heterogeneous disease. not all the lesions express somatostatin receptors. So this patient is not really a good candidate for PRRT, as opposed to this patient has mostly liver disease, and you can see how active are these lesions in the liver. They're all very active. So this patient is definitely a candidate for PRRT treatment, radionuclide treatment. And even within the same lesion, sometimes the pattern can be different. This is a patient from the literature that you can see has large liver lesions that are very positive on dotted PET. However, there is a component of this lesion that is not positive on dotted but has FDG uptake. So there is probably a component of these large lesions that is more aggressive, and theoretically one could conceive a combined treatment with PRRT and the liver-directed treatments in patients with this heterogeneous disease. So in general, this is how PET can be used to direct the treatment, to assess the biology of the tumor, and for more targeted treatment. So the goals of imaging in neuroendocrine tumors is also to assess response to treatment after systemic or local treatments. Again, we have the ability, the possibility to use CT, MRI, or PET imaging, and also to restage the disease to assess treatment changes. So after the treatment is complete, again, the use of CT or MRI or PET to see how the tumor has responded to treatment. So I'm going to show you just a few examples of how CT and MRI can both help in the assessment of the disease and how the disease has responded to treatment. This is a patient that had few, you can see here, lesions in the liver. They were positive on dotted PET CT in a baseline. At follow-up, the lesions seem to be stable on a CT, but actually we do see a little more lesions in the liver. So there was a question of disease progression. So this is how the integration of the two helps. This is a phenomenon that we have seen sometimes in the patients. So pseudo progression of the lesions, as the lesions are treated with the radionuclide treatments, because some of the cells die off and there's necrosis, they seem to be larger. And so this is what we think is a pseudo progression. But then if you compare this imaging with the SPECT images of the lutetium-177, you can see that these lesions really have not changed. So even if it looks larger initially on the CT or MRI, then eventually this is not going to grow further. Again, it's a pseudo progression. So PET CT or SPECT CT can help in verify what is the situation of the tumor. And again, same thing here. There seem to be a pseudo progression of this metastatic pancreatic neuroendocrine tumor. But if we compare, so some of the lesions seem to be, I'm not sure if you can see, seem to be more lesions, larger lesions. But comparing with the PET before and after treatment, again, you can see there is less activity and fewer lesions in the liver comparing these. This is another example how the two imaging modalities combined can tell us how these lesions and these lesions here have definitely improved after a treatment with the PRRT. As you can see, this overview of good improvement. This was a patient with an inoperable pancreatic neuroendocrine tumor treated with lutetium-177. As you can see, this is a large lesion at baseline, and the lesion got smaller and smaller. So both in CT and the PET or SPECT imaging tell us that this tumor is being successfully treated. So in general, this is just an overview slide of how we can, while we assess response to treatment, typically the patient at diagnosis with a CT, MRI, and PET, and then we're going to treat the patient PRRT or systemic treatment. We typically follow up the patient with CT or MRI and do PET only if needed, and only towards the end of the treatment. After the end of treatment, we typically wait 3 to 6 months. We do a CT and then PET if needed a little bit later on, at least 6 months after the end of the treatment. This is some of the appropriate use criteria that have been published. As you can see here, hopefully it's not too small, but PET CT is appropriate and is very helpful in initial staging, localizing a primary tumor, in staging the disease, selection of patients with for PRRT, in staging neuroendocrine tumors when surgery is planned. Again, evaluation and better evaluation for masses, which is suggestive of neuroendocrine tumors, but not confirm, of course, the presence of uptake on PET that would strongly suggest that that mass is a neuroendocrine tumor. Again, in monitoring of neuroendocrine tumors, predominantly positive on PET. So obviously, if they're very positive on PET or seen on your PET, that management, that PET follow-up is very, very important. I've just a few seconds on new PET agents. These are now approved agents, the copper-64 dotatate, as opposed to the previously approved gallium-68. Now we have this addition, which is available. They're very comparable, gallium-68 dotatate and copper-64 dotatate. Main difference is the longer half-life of the copper-64, which is logistically is favorable and can allow proper dosimetry. Again, these are study comparing copper-64 and without imaging agents. Essentially, the clinical value is very, very similar between copper-64 and gallium-68, and also label agent, and also compared to a third now approved agent, which is gallium-68 dotatalk. So I am at the end of the presentation, and I would just wanted to go over a summary slide here, just to summarize again what we have discussed. Integrated assessment of imaging with structural CT or MRI and PET is very, very important for initial staging and tumor biology. Assessment of the prognosis, so establishing true tumor burden, assess whether this is progression for planning the treatment, whether it's PRRT and other systemic treatment versus liver-directed treatment, or for the combined treatment of these patients. So thank you so much, and I'm going to see if there are questions. So hearing no questions, I would like to, first of all, I'm going to stop my presentation. And again, thank you all for attending. And I would like to introduce the next speaker, which is Dr. Eric Liu. Dr. Eric Liu, hi, Eric. YEM, yeah.
Hi, Giuseppe, how are you?
Good, Eric. Thank you again for being part of this.
Oh, thank you for having me. Yeah, you know, it is 7 o'clock in the morning here.
I was actually thinking about that. I said, what time is for Eric? So great. So especially for that, considering that also on a Saturday morning, thank you so much, Eric, for being part of it. I'd just like to want to spend a few words on Dr. Liu. Dr. Liu is a specialist in neuroendocrine tumors and related endocrine malignancies. He's originally from Maryland, from here where I am, and he attended the Harvard University and Columbia University, so where he had his medical degree. Then he did his general surgery training at the New York Presbyterian Hospital and the research fellowship at the National Institutes of Health. He is specialized in endocrinology surgery and the cell transplant. And then he went to Sweden for an endocrine oncology unit, a very prestigious center at Uppsala University, again in Sweden, studying specifically neuroendocrine tumors. He was then an assistant professor at Vanderbilt University, where he developed a multidisciplinary neuroendocrine clinic. And his team was actually the first to perform a gallium-68 dotatate PET-CT in the United States for neuroendocrine tumor patients. He's widely published, gives frequent lectures on the topic neuroendocrine tumors. He's a great speaker. He is currently one of the co-founders and the directors of the Neuroendocrine Institute in Denver, in Colorado, which is a multidisciplinary clinic dedicated to treatment patients with neuroendocrine tumors. And he's also chief medical advisor, a co-founder of the Healing Neck Foundation. Eric, thank you so much. It's always a pleasure to have you.
Thanks, Giuseppe. It's great. Do you remember when you had to read those Octria scans, Giuseppe? Do you remember those things?
Oh man, I do. And I had to say, I did feel sometimes it's not possible that I don't see any tumor in this patient, right?
Yeah,
And they always
exactly.
say there must be tumor somewhere. And so really, PET has made a huge difference. It's changed the world for us.
Yeah.
I don't think anybody who has a PET obviously is doing a octreotide anymore.
Yeah, no,
So that was good for you too, right?
Oh, it was huge for me. Well, I consider myself a little bit of an amateur nuclear medicine doctor, amateur nuclear medicine doctor, because there's no question I could not read an Octria scan. But once those PET scans came along, they were so helpful, and they were very helpful for us in surgery because we did not know what to go for. There was a day I relied on you to tell me where the tumors were. Yeah. And so now the PET scan allows us to do that. So it's a great segue into our talk. Well, thank you, Giuseppe, for having this session and having me. And this is fantastic. And I thank the Ruesch conference for having a neuroendocrine session. It's really, really great. So my job in the next half hour or so is to talk about surgical intervention of neuroendocrine tumors. And this is a chance for me to kind of just highlight the importance of surgery for neuroendocrine, which I think is very important. But as I say all the time, I think one of the most important things if I can leave you with any kind of a thought or any kind of a small piece of advice for especially the patients who are on, is you should definitely work with a specialist, okay? Neuroendocrine is a little bit of a different disease. When you get the diagnosis of cancer, which is really horrifying, how you approach it, how you think about it, how you space out the treatments is extremely important. And having someone who understands that this kind of disease and the pace of it and the tempo and the biology and all those kinds of things is super, super critical. Anyone on this panel obviously can guide you through it. But when you work with someone, say, who's a specialist in bladder cancer or a specialist in just liver cancer, they may not understand neuroendocrine perfectly well. And believe me, when I take care of people who have regular pancreas cancer or regular colon cancer or something like that, or regular stomach cancer, it's a totally different beast because it's a totally different disease. So please, if you get a chance, work with a specialist. I think you'll see the vast difference. Now, my goal for today is just to do a couple of things. I want to show you what the roles and the goal of surgery are, okay? Because I think a lot of people, including medical oncologists and people who don't do surgery, don't totally understand it. And so they may tell you that surgery is not an option. When in fact, it's always an option. It may not be the right option, it may not be the right time, but it's always an option. And so we should think about how it can be used. So surgery, despite what you hear about it, and true, it's very invasive, and true, you need general anesthesia, but I can do a bunch of things. I can help make a diagnosis, right? So if Dr. Esposito struggles to see that tiny little neuroendocrine tumor in the bowel, I can go in there and find it for you, because I always tell people, the best imaging agent is actually these 10 fingers, right? That's actually very, very helpful. I can sometimes, sometimes it's a 4-letter word, but sometimes I can cure people of their tumors, right? But really what I can do is I can sometimes really very much prevent complications, very much life-threatening complications. And very frequently, I can help people with their symptoms and improve their quality of life. And so there's a lot of benefits to it. And whether you do what's called a complete resection, where I can get the whole thing out, or even if I can just debulk it and get 70, 80, 90% of the disease out, the patient benefits. And since we're looking at such a long course, every day that I can make you feel better is very, very important. So you can see here, my job is to say, well, what is the risk of the operation and what is the benefit of the operation? And hopefully the benefit significantly outweighs the risk. So just as a little bit of a survey, right? So these are the types of therapies, and our colleagues on the panel are going to discuss these things. So surgery, I think of as what's called a local regional therapy. So kind of a small area or a general region, kind of in the belly or the chest, is where we can really thrive and help you. There are other treatments like suppressive hormones. I'm sure Dr. Schlossberg will mention these things, but these are systemic treatments that he specializes in: hormone synthesis blockade, molecularly targeted therapies, chemotherapy, embolization, right, to the liver is a regional disease. We'll hear all about that. And of course, the PRRT that Dr. Esposito just talked about. But those are systemic treatments. And sometimes systemic treatments, if you're very lucky, get things to shrink. And if you're not lucky, even if it's successful, it'll hold still. But it may not necessarily fix the problem. Does that make sense? And so the goal is very much to fix the problem. So if you want to think of me as the plumber or the carpenter or the, whatever you want to think of me as, I think that's very reasonable. Now, the issue is that surgery is very complicated, and when to use it and how to use it for various organs and things like that, requires a fair amount of judgment experience. So this is a picture of me when I was much, much younger, as Dr. Esposito mentioned, when I was a visitor over in Sweden, in Uppsala. And I met with my friends there, and they taught me a lot about neuroendocrine, and they had done a lot of research on their experience because they had seen so many patients, and they found that if you could do surgery for the patient, they would do much better. So for example, if you could get the tumor out from the primary area of the small intestine, which happens to be the most common place for one of the most common places for neuroendocrine tumors to come. And it is actually the most common cancer of the small intestine, these little carcinoid / neuroendocrine tumors. And if you could get the liver out, if you could get the lymph nodes out, these people did much better. And our colleague, Dr. Per Hellman, who did a lot of the surgery, he found something very simple. If you could remove the tumor, the primary tumor, that was an indicator that the patient would do better. Now, it's not always just because the surgery necessarily fixed everything. It frequently does. Don't get me wrong, it frequently does. But sometimes it's just an indicator for a more indolent disease. And so you can see here the curve on the left side. So you can see it drops off faster, where the people who could not get their primary tumor resected, and the one on the right side are for the people who could get their original tumor resected and removed to have surgery for. Now, I don't really understand it because I can get every single one of them out now. So I don't know why anyone could not get their original tumor resected, but this is what he found. So there's benefit to that. And it's been replicated many times. Our colleague, Dr. Pommier in Oregon, he found almost the exact same thing when he could remove the primary. Our colleagues in the UK found the same thing. And if you could remove that primary tumor, people did better. And our colleague right here, our honored colleague here, Dr. Strasberg, found the same type of thing, where if you could get the primary tumor out, the patient did a little bit better. And if you look carefully kind of at this curve, especially in the first several years, right? Remember, this is in weeks, right? This is in weeks. So we're talking about 5, 6, 7 years. You could really, if you could get that primary original tumor out, you could really push this curve over to the side. And that's what we're trying to do. Now, whether you do it today or tomorrow probably doesn't matter. So our colleagues in Uppsala, again, in Sweden, looked very carefully, and they found that if you had patients, and it seemed, if you didn't analyze it very carefully, if you delayed their operation, they did worse. And you can see that little darker blue curve on the side there, they did worse. But then when they looked very carefully with statistics, if you delayed their operation a little bit by a year or two, or maybe when they became symptomatic and things like that, they were fine. And so there's no rush to doing surgery. If you don't feel well, if there's a problem to fix, if you're vomiting, if you're losing weight, if you're having abdominal pain, that's a very good reason to get it fixed right away. But if people are asymptomatic, which we have many patients who are asymptomatic, maybe you don't have to do it today, right? Just because I have a gap on my OR schedule next week doesn't mean that you need surgery next week, right? So those are the things to think about. So I always tell people we have the luxury of being able to think about it, figure it out, get all the scans, right? Do the dotatate scan like Dr. Esposito does every day, and figure these things out. And then we can make the best decision. And so that's very important to understand. Now that's intestinal surgery, which is the most commonplace, but surgery in the pancreas, which is another very common place, is a little bit less clear. there have been some older studies, right? It's not yesterday. These are some older studies. And they found that if people could get the tumor out, that was mildly helpful. But it also depends a lot on the complication, because the pancreas is a much angrier organ. Dr. Marshall here is a specialist in these kinds of advanced cancer, so he knows. But surgery for the pancreas is tricky, and there's a higher risk to it, and you have to think very hard because people can change. And so, as I always look to, Dr. Strasberg's mentor, Dr. Coles, was a real giant in our field who we stand on his shoulders. And he said to us, if you could do aggressive surgical resection in selected individuals, so that means I have to think very hard about them, and it can be performed safely, it may improve symptoms and it may improve survival. So that's the issue. If I can do it, if I can do it well, and I cannot hurt the person, then we should definitely think about it, okay? And when I say think about it, it's important, because here's an example. This is a 70-year-old lady. She had a chest CT scan for something totally different. And they found this little ditzel thing in the pancreas. I don't know if you can see it. I don't know if I have an arrow here, but there's a little white dot right kind of in that middle above the spine there. You have to tell me if I'm doing it right. And everyone, she saw multiple surgeons in the area. And they said, oh, you have to have what's called a Whipple operation, where they remove the head of the pancreas and they cut it out. Now, don't get me wrong. I've done this operation many times, and people are not the same after the operation as they were before. Sometimes they do great, and sometimes they do terribly. I said, no way. You're not getting this operation. You're perfectly healthy. You're asymptomatic. You're 70 years old. There's no rush to it. So I followed it for several years. And if you can tell me, any of you radiologists here, if it's changed or not over the years, you can see it hasn't changed at all. So sometimes it's just a little growth and we just leave it be, but it's complicated. Because if it's a growth, and here you can see our colleagues have analyzed this in the SEER database, sometimes you can just watch it. And what they concluded was, if the lesion was relatively small, about 1 centimeter, I actually use 2 centimeters as my cutoff, and they're not symptomatic, you may not have to do anything terrible to them. So that's, but again, it takes experience and takes a lot of thinking, and it takes a lot of analysis and study to figure out if that's the right thing to do. But again, surgery is not perfect. Surgery is not perfect. A lot of people who have metastatic small bowel disease can have very complicated issues, and they can definitely, those hormones and things that come out of the tumors can be quite angry. And so when we do surgery, so, luckily at our hospital, we do it almost every day. We do, this kind of surgery. We know what to do. And so what we used to do, we still do, is we often treated patients with a lot of octreotide, which is that hormone that helps suppress the other hormones in the tumors. Maybe there's a little bit of controversy now. We have our colleague, Dr. Palmier, has done some really interesting research in this, and he has not found it to be very effective. So we're starting to rethink these things. But again, if you're going to have a major operation, it really helps to have it done with someone who's a specialist who does this all the time, and with a team that's done it a lot too. And some of the other medical things we worry about, for example, is that some of the medicines that Dr. Strasberg gives you, they can cause problems. For example, they can cause gallstones and kind of gallbladder problems. And so sometimes we need to take out the gallbladder at the time of surgery. It's a lot easier for me to remove it, 15 minutes, I can remove it during a big liver operation, compared to having to go back there after all the belly is scarred in, and it can be difficult. But sometimes the situation is quite challenging. Patients can have a lot of scarring, they can have blocking, they can have loss of blood flow, they can have all these things. And so if you're going to have this kind of surgery, you really want to have someone, again, who knows what they're doing, and an anesthesiologist and a medical oncologist and interventional radiologists and nuclear medicine doctors who are very familiar with the disease, because they can help you more. So it is a little bit early in the morning, but if you all are okay, I would be happy to show you some pictures of some gross surgery, some squishy organs, because that's what I do all day long, squishy organs. This is it. It is not super impressive. So the original tumor you can see on the left is that little white dot, a little white line, that stripe. And what it does, you can see it just kind of scars down, and that's it. But then it can turn into the picture on the right. That's a liver with a whole bunch of little tumors inside there. And so this patient would be a good candidate, for example, for Dr. Esposito's, say, PRT treatment. And so we would, I don't know why, but this is how it works. It's different from other kinds of cancers. Usually the original tumor doesn't grow very much. And I know that because every time I look at it, they're always small, right? So here's one there, that little classic white stripe. Here's one, which is a little bit more subtle. You can see there's a little change of color there. And sometimes you can barely see it at all. And so it can be a huge challenge. And that's it. It's this little ball. And that little ball can cause blockages and cause problems, and it can spread. It's a fascinating disease, but a little weird. So the next place it goes is what's called the mesentery, which is all that supportive tissue with blood vessels and lymph nodes that feed your bowel and help you digest your food. And they go to the mesentery, and there it is right there. And you can just, if you really want, you can probably take a 9-iron and hit it out. That's what I always want to do. It looks more like a golf ball than a tumor. But that's what it is. And it causes problems because it scars down and it causes people's stomachs to hurt because now your intestines get tangled up. And sometimes you can have multiple ones inside the same area. Look at this. 1, 2, 3, 4, 5 different tumors within the same specimen. Can't tell you why, it just is. But we watch out for these things, and we are very careful to try to remove them all. And you can see here, there's a reason why people's stomachs hurt sometimes, right? Sometimes that tumor can literally tie your intestines into a knot, and no amount of PRT or no amount of sandostatin or lanreotide is going to fix this problem. It is a mechanical problem. I have to go in there and fix this for you. And that's what we do. And it helps people a lot. And you can even see here, I know this is a little bit subtle, but you can see right here, that's the intestine on the left side there of the screen. And it's not happy. It has like fuzziness around it. It has a little bit of kind of unclarity you can see there. And this is what happens when you remove it. It is actually very unhappy because the blood flow to the intestine is poor because of the tumor. You see that big fat purple stuff on the right side? That is sick intestine, and that makes your stomach hurt all the time. Versus the little pink spot, I pulled that up only so you can compare the pink bowel on the left there. Here's another better example. You can see sometimes the intestines are purple because of the lack of blood flow. And I pulled up that pink one there so you can just compare. This is why people's stomach hurts all the time. And the reason is because you can see here, see that blood flow right side there? There's that white blood vessel inside there. Well, these tumors go and they just really muck up the way the blood flows to the bowel. And so my job is to get that fixed up. Now, I have to do it carefully and safely because there's no question if something goes wrong, we could definitely lose a lot of intestine. I can hurt people more. But we have lots of really interesting techniques. Take a look at this. This is a case actually I did just on Wednesday, and so I wanted to share this with you. It is a, oh, it's too bad. Okay, sorry, it was a movie. But what it does is it demonstrates the ability for me to watch the blood flow into the intestines so I can determine if the blood will go into the intestine. So I'm sorry that the movie didn't work. It was really quite impressive. But it's a really important technique, and it allows me to do very, very safe surgery to help you. Here's an example of a pancreatic case. This lady was actually relatively asymptomatic, same type of thing, had a CT for something totally different. And they found this gigantic mass in her pancreas. And so we removed it, and you can just see how big it is. These things can get quite large. Now, in the pancreas, which obviously is a very complicated organ, we have to be careful. The major complication is a blockage, much like the blockage of the small intestine, which causes pain. You can get blockages that cause what's called pancreatitis, but the most life-threatening one is where you get what's called splenic vein thrombosis. It is a large vein that goes right behind your pancreas. And when you have a big tumor just like this that blocks it, it prevents the blood flow from coming back. So just imagine if there was an accident on 495, right? So I really did grow up in Maryland. If you had an accident on 495, the whole city would shut down because you could not drive on the major highway in Washington, D.C. And if that happens, well, then you're stuck going on the local roads. And that's essentially what happens when you have a large tumor. I've seen it so many times. And then when you get this, what's called splenic vein thrombosis, then all that blood flows into places that it doesn't belong. Okay, so you can see a very large tumor kind of on the right side of the screen there. And it's blocked up and swollen, and the spleen is angry. I mean, there's so many problems. And here's what it looks like in the operating room. You can see that is not natural, right? If you look on the left side of that little vein, that's what it's supposed to look like. But when it gets clogged up, it looks like this. And the problem is that vein, as you can see, kind of goes into the stomach. You can see just a little bit of the stomach in the bottom left-hand corner there. And then you can get what are called GI bleeds. So you can bleed into your intestines and your stomach. And that can be, without question, life-threatening. I've seen so many patients who require transfusions and emergency endoscopy to try to repair these things. And so if I can prevent it up front, then I think the patient always does better, because it is truly, truly life-threatening. Here's what a pancreatic neuroendocrine tumor looks like. It looks like this little creamy thing. It's nothing fancy. That's what it looks like. That's a small one, obviously, not a super large one. But the interesting thing about these tumors is they can be very, very different. I cannot tell you why. And I've gone out and picked out thousands of these things in my career. But there's a tumor that comes from the bowel, for example, and then it has this whole family of tumors. And I cannot tell you why the one on the left side is probably 300 times bigger than the small ones down there. It just is what it is. And they can go to other places, right? So we talk about the liver, we talk about the primary tumor, where it originates from, but frequently they go into the ovaries. So you can see here, this used to be a uterus in the middle with 2 ovaries on the side, and those are clearly not normal ovaries. And they are not because they are completely filled with the tumor. And so we do these things because they cause pain and discomfort for patients. And on top of that, the ovaries, for example, have a lot of blood circulation, much like the liver. And therefore, the hormones can travel through the body and actually make people more symptomatic. So we have to get these tumors out to help people feel better. And look, I didn't make this up, okay? I'm not that old, I don't think, but I've been doing it for a long time. But I was taught by people from big prestigious institutions, such as, I'm in private practice, so it's a little bit different. But these big prestigious universities, such as Mayo Clinic, Louisiana State University, Canada, they have found that if you can go and debulk these people and get them cleaned out, surgery is an extremely beneficial therapy. And if you want to call it palliative, just like kind of you're trying to help people, that's fine. But if I can palliate someone for 25 years, I think that's a very reasonable thing to do. And I can get out a lot of these tumors. I mean, it's tedious, but I can get a lot of these out. And as Dr. Strasberg will show you, part of their goal is to have a complete response. Well, I can do that. I can actually give you a complete response in about 3 or 4 hours. And it's weird. I can't tell you why, but you can see sometimes the tumor, this one on the screen right, is a very large tumor, and the other ones we pulled out too. And there's one that's a little bit different. You can see here. So this is the what's called a cystic neuroendocrine tumor, if we look very carefully. The only reason I knew it was a tumor, because cysts, which are just fluid-filled balls, are very, very common in neuroendocrine. I'm sorry, in livers, in general, in livers. But this one was actually a neuroendocrine tumor, which was also cystic. And the only reason I know is because that scan that we developed showed me that the rim, not the inside, but the rim was neuroendocrine. So thanks to Dr. Esposito, he says, Eric, don't forget to remove that tumor as well, because it's not a cyst, it's a tumor. And so really not all the tumors are the same. So I don't think this is going to work because it's a movie, so I apologize. But this is a tumor in which it was growing and expanding, and the medical oncologist wanted to give chemo because it was growing so fast. But it turned out it wasn't. When I cut into it, all the blood comes out of it. So it was actually a bleeding tumor. It bled into it, and the blood was pushing out like it was a balloon. Here's another example. Actually, this lady actually lives in Virginia. And so she had this big tumor. She's seen many, many specialists, and everyone said they could not remove it and it was not safe and things like that. So she came out to see me. And you can see it's this big fat ball right in the middle of the liver. You see that there? So we removed it, and she looks fantastic, and she looks great. And so sometimes, we using surgery in the right hands is very important. And so what I tell people, especially our colleagues, if you believe in taking out these kind of metastases, the way when it's spread out, in our more traditional cancers, such as colorectal cancer, then you must believe in it in neuroendocrine as well too, because neuroendocrine surgery is very different from what we call adenocarcinoma, which is the more traditional kind of, scary kind of a cancer. And our colleagues at Memorial Sloan Kettering, well over 20 years ago, established the removal of tumors from colon, cancer from the liver. And in fact, the survival is even better. You see, our Canadian and our Mayo Clinic friends have found that survival was improved compared to colorectal. And colon cancer is very standard, and this is very standard things that we do. So if you believe in it for colon cancer, you need to believe in it for neuroendocrine. And it just helps people a lot. You can see this curve here on the left, their symptoms. It's not perfect. I got that. It's not perfect, but their symptoms are improved. Their performance is improved. You just have to remember the disease will always come back. It is a microscopic disease. So even if I can remove this, but if I can remove the stuff that has already proven to grow, then hopefully the small microscopic stuff will still be very, very quiet. And then Dr. Esposito and Dr. Strasberg can control those things with medicines. And again, surgery can be very complicated because there are lots of different organs that behave very differently. And so when you get inside there, you have to understand there's different types of surgery. So we may have to, remove a piece of small intestine from what we call the ileum or the jejunum. That works well. Sometimes we remove it because it's in the corner near the colon. And so it's all different. But the good imaging is so critical. As Dr. Esposito said, he used to read terrible, terrible scans. Now that our scans are so much better, it helps because if I can see, for example, in the pancreas, right? If it's a teeny tiny little tumor, then I can just kind of scoop it out. It's not perfect, but it works pretty well. Sometimes I can remove a piece of the pancreas. Sometimes I can remove just one portion of the pancreas where the tumor is. Sometimes I can do it with a robot. Sometimes I can do it laparoscopically. And sometimes you just have to do it open because the tumors can actually be very big sometimes. And sometimes you have to do what's called a Whipple procedure, which is a big operation for the pancreas. So a lot of it requires a lot of judgment. And again, the most important thing is that I can see it. I can see it. I can see it. So you can see even that little black dot there at the end of what's called an ultrasound machine is critical for me to do a safe operation. Now, again, I didn't make this up. Very brilliant people like Dr. Strasberg and everyone here on here, they have told me on the NCCN guidelines that doing surgery is very important. So always try to do surgery. It's not perfect. I've said that many times, and there's definitely risk to it. But when it's done safely, it is a wonderful technique for helping people, one, feel better, and hopefully help them live longer. So thank you very much. I appreciate it. I just want to let you know that there are many people out there, including the people on this panel, who are doing research and taking care of you and thinking about it. And so it's a real pleasure and honor to be a part of this community.
Wonderful. Thank you so much, Eric. That was great and perfect timing. So everything's great. Thank you so much. So I see that there's one question from the audience. And so if okay, maybe we can leave this question towards the end, because unless Dr. Liu, you want to, the question is what kind of treatment is appropriate for each grade tumor? Obviously, this is...
Okay, well, let me answer that real quick, because I think it'll set up some of the things that our other colleagues are going to talk about. So the grade of the tumor generally gives you a sense of how fast the disease grows. And so surgery is generally much, much better for slower growing tumors, right? Because you want to get the benefit of the long duration. If you have a very, very fast growing tumor, the surgery doesn't help because it grows so fast. The moment I remove it, 2 weeks later, it's going to grow back. And so we worry about those very aggressive cancers. But right in the middle, it requires a little bit of judgment. And so, as I said, surgery is always an option, which is always why if you work with a specialist, we can determine if it's the best treatment, well, one of the best treatments for you in combination with other things. But sometimes when it's an aggressive cancer, you must have chemotherapy.
Well, very good. Thank you so much. And then when Dr. Cohen and Dr. Strasberg have finished the presentation, I guess they might, of course, have some additional information on this. We'll keep that question in mind as still unanswered. So thank you again, Dr. Liu. And I'm going to introduce the next speaker, who is Dr. Emil Cohen. Dr. Cohen will be discussing about the liver-directed treatment in neuroendocrine tumors. Dr. Cohen, again, thank you for joining us. And again, on a Saturday morning, be willing to participate in this session. Dr. Cohen is an associate professor of vascular interventional radiology at the Georgetown University Hospital, the Metzler Georgetown University Hospital. So we work a lot together. He earned his undergraduate and medical degree from the George Washington University, still here in DC, and completed his training at the Mount Sinai Medical Center in New York. His interests include interventional oncology and vascular disease management. He has numerous publications, presentations in these fields. He's a great expert in, again, treatment, liver-directed treatment in cancers and including neuroendocrine tumors. And again, within our Georgetown clinic, we work a lot together with imaging for his treatment. So again, it's a pleasure to have you, Dr. Cohen. Thank you, and I think you're ready to start. Thank you.
Okay, let's, like any old person, I gotta make sure my presentation is showing up first. And thank you, Dr. Esposito and Dr. Marshall, for inviting me to speak at this conference. I want to make a note on the last presentation. Don't believe the surgeon. He is always up, I'm sure, at 5 o'clock in the morning, because I know surgeons are up early and working very early in the day. Having said that, let me go ahead and advance to the next slide here with what the question is for this topic. We are going to be discussing a lot of different therapies, and I think one of the things that always comes up with my patients is, what is the best treatment option for my tumor? And the ones that for palliative treatment frequently ends up being bland embolization, chemoembolization, or radioembolization, or none of the above. So we leave that question B for the time being and let you vote on it for a second. Music is muted. Exactly, yes. As the audience has already predicted, there's no definitive benefit. There's some harm with one or the other, but there's no definitive benefit of one over the other. So let's keep going with the talk here. All right. So the grand, like 10,000 feet view of what we're going to be talking about is what IR can offer to help people either feel better or survive longer, or both, hopefully. The two categories we can think about are either ablative therapies or intra-arterial therapies. With ablative therapies, we try to overlap with Dr. Liu's field, surgery, to try to minimize the number of tumors a patient has. Having said that, that also means that ablative therapies are basically good for patients who have very limited disease. And we used to do it for only up to about 3 tumors, but more and more studies, not just in neuroendocrine, have come up showing that even if you go up to like 5, 7, or even more tumors, it may prolong survival for the patients. The intraarterial therapies are more for palliation, which means we don't really expect patients to live without any disease, but we do expect them to live longer with the disease being present. So what about the ablative therapies, the first broad category? I'm going to actually go ahead and put the PRRT therapy in this area because this has been shown to basically push back tumor a lot, and it's almost as good as like some of the chemoembolization ablative therapies we do to help patients. But for doing our ablative therapies, again, we're going here for cure. We have to have, as Dr. Liu and Dr. Esposito have pointed to, we need to have really good imaging to kind of get an idea of where everything is. We need to know the exact number and size of tumors that are present, The non-invasive images Dr. Esposito went over is excellent at it. And sometimes when we need to address the liver, which is what I do about 90% of the time, we just need even better imaging for that, which we get with MRI with hepatobiliary agents. So again, the dododate scans and more advanced versions of that are obviously the best way to go to find as many tumors that are present all over the body. But when we get to the liver, because that's one of the primary sites where we have tumors spread to, an MRI can give you a little bit more resolution once you to figure out exactly how many tumors the patient has. So if it makes a difference whether the patient has 1 tumor or 5 tumors or 20 tumors, and you can't get that exactly, and that makes a difference in your management plan, then again, MRI with liver-specific agents is a very good tool to have. Again, you want to have very good local control. Again, we are helping the surgeons. They're running the show with as far as getting the disease under control with cutting it out. And if they can't get to a few locations, we can certainly help in IR to get that done. On the other hand, if the patient is not a great surgical candidate, we do things much less invasively with much less additional risk factors. I'll also discuss some liver regeneration tools to help the surgeons achieve their goals. So what are we talking about here? As I alluded to, MRI with liver-specific agents. These are agents that are picked up by the hepatocyte, the liver cells specifically, and aren't picked up by the tumors, help us differentiate normal liver from abnormal liver or tumor. And when you look at neuroendocrine tumors, this is great for them. When you do a conventional MRI, you found maybe almost 9 out of 10 tumors with just conventional MRI. When you add this additional phase, you get that 1 or 2 extra tumors that you would not have seen otherwise. And that's important because whether you're having surgery or percutaneous ablative treatments, you want to get rid of all the disease, as was alluded to before. And why do we do ablations? Again, just as we're trying to emulate what the surgery team tries to do, which is to try to get rid of all the disease as possible. And we have very good success with these treatments if you look at it based on the tumor size and volume. So when you look at ablation of these lesions, the survival of the patients with neuroendocrine tumor undergoing these procedures is very long, and sometimes decades, on the order of decades. So if you're looking at the sizes specifically, you see that if we're doing percutaneous ablation or even surgical ablations, having the smaller tumor, we have better luck of getting the disease under control completely. For instance, if you have a tumor under 3 centimeters, what I tell my patients is that we have an 85 to 95% success rate of getting rid of the tumor. And of course, location matters a lot in this equation, but once I see patients who have tumors greater than 3 centimeters, you see a great sharp drop off in survival benefits from ablation procedures. Now, with newer techniques such as microwave, this is what data is from RFA, which is an older technique. We're seeing better results, but again, the 3 centimeter cutoff is a good way to look at things. Another study that was done does meta-analysis looking at how ablation of these lesions work out when you do either through the skin or with surgery. You see that sometimes with concomitant liver resections, you're able to control patients' symptoms in over 90% of the patients using this approach. You can also, the other advantage is that you can repeat this as many times as you can. In fact, if we feel like that nowadays where we're doing more and more tumors, we may have to split them up into more than one session. You can easily get away with doing like 3-4 tumors in one session, but if you're going more than that, you might want to split it up into 2 sessions just to enable the liver to regenerate and also the patient to feel a little bit better before having another hit to the liver. That being said, it should be noted that most of our patients are in and out of the hospital within the same day frequently. Now, 90% of my patients, when they get an ablation, go home the same day, which is great. It's not to say they're feeling rosy, but their pain is under control, they're eating okay, and they're walking for themselves. They're not running miles or anything have you, but they can certainly go up a couple of flights of stairs. So getting them back home, getting them back to their routines is actually very important for us to make sure that it's not just them surviving, but also that they're able to capitalize on their survival time. Here's some example of what we see. We love these small lesions here. You can see that in this CT scan of the liver, there's this area, this low density area in the liver. This is what the normal liver looks like. We have put an old RFA probe in this lesion, and when we finish doing the procedure, the area looks bigger. That's because we're not only hitting the lesion, we're also expanding the area of ablation to make sure we get all those small foci of cells that are around the lesion. And when we follow the patient a few months down the road, we see that the lesion is gone. There's some retraction of the liver because that part of the liver dies and gets slowly absorbed by the patient's body and goes away slowly, this is exactly what we want to see after we treat a lesion. As far as what we have that's changing, well, the thermal techniques, whether it be freezing or burning or electroporation, are all nice, but the biggest advance we've had in recent few years has been the fact that we can direct our needle and get to lesions that were traditionally hard to get to. So this is a very good example where we have a patient who has a lesion here that is next to the heart and the inferior vena cava and the lung too. So whereas we used to put these patients on a CT scanner and be like, well, now I have to go to the breast tissue, whatever have you, and I'm going to get really close to the heart. How can I be sure I don't cause any damage to everything? And sometimes we'd even say like, no, we can't do this. We might as well do some other treatments to try to treat this lesion. Nowadays, we can bring the patient in, put them on our angiographic table, and go after the lesions in an unusual fashion to try to get to them. And as you can see on the animation, the needle has a very oblique course to where it's going, which is something we wouldn't do with a CT exam, but we can do with our angiographic tables and basically get them in you can see this on the right, under very unusual angles and get lesions we weren't getting to previously in a safe fashion. So let's move on to the next part of the talk and talk about the lion's share of patients we treat with neuroendocrine tumor, because unfortunately, the patients we see have more than 2 or 3 foci of disease frequently. So what do we, as Dr. Liu pointed out earlier, and you will see this again and again, where are we in this whole schema of things? Well, you can see that the patients have a lot of choices, but if or when they progress, we have regional therapies to help patients, and the patient fortunately has a lot of choices here between PRRT and us. And later on in the talk, we'll talk about if it matters which order of therapies we follow. The choices we broadly have are bland embolization, which I always tell my patients is basically shooting little plastic balls into the artery to close them off. Chemoembolization, loading those little plastic balls with chemotherapies and putting them in there. And then finally, radioembolization, which means you either have glass or plastic spheres that have yttrium-90, a radioactive agent, beta blocker, into the arteries. All of these are great ways to tackle things, but we'll see as the talk goes on, there may be some advantages or most importantly, disadvantages to one of these techniques. So what patient do we want to go after? We want to go after people who have liver-only metastatic disease or liver-only progressive disease. As PRRT has progressed, has been a great treatment, or systemic chemos have progressed, we've seen great results with them. We also see the weird situations where we have disease control all over the body, and there's only a few tumors in the liver that are actually getting bigger. Similarly, because of the way neuroendocrine is and the fact that the portal circulation, the blood drainage for the guts and pancreas go to the liver first, we see patients who present with just liver-only disease. These are patients that you want to tackle with regional therapy to basically beat back the disease and buy the patient time, not just only in survival, but relief from their symptoms if they're having any. The key is to get the patients under treatment as soon as possible, because no matter which one of these we do damage the liver to some extent, and we want to have enough liver reserve function to not cause liver failure after we treat the patient. So why does this work? Well, the liver is, as I mentioned earlier just in the last slide, has 2 sources of blood: the vein that drains the gut, the portal vein, as well as the artery. So like every other organ, the liver has an artery that goes into it and supplies it but it actually gets most of its food and oxygen from the portal vein. That's the blood draining from the gut as it does its processing. In fact, back in the days when people would get into car accidents in the 1950s and the 60s, the surgeons could go and just tie off the artery completely if the patient, God forbid, was bleeding to death, to prevent him from passing away. And most patients, the key is most patients wouldn't notice any difference from having their liver artery tied off here. And of course, there are veins draining the liver out of the liver. This is in comparison to the tumors in the liver. These up to about a quarter inch can just survive off leaching off the food and oxygen that's around them. But once they get more than like a quarter inch in size, they will send out signals saying, hey, I need my own blood supply, and the body, not knowing any better, responds to it by sending arterial feeders into these guys. So let's just step back. So the normal liver is getting the majority of its food and oxygen from the portal vein, but the tumor is getting the majority of food and oxygen from the hepatic artery. Now, what the analogy I tell my patients is that if I was to put a small tube into the artery and just give poisons, the tumor would see a much higher concentration of that than the normal liver would. It's not to say that the normal liver wouldn't get any of that. It's the tumor would get much more higher concentration. And as we know, with radiation or poisons or whatever have you, the concentration makes a big difference in how much damage you cause. And we want the damage to go to the tumor mostly. Which patients don't want to treat? Again, as I alluded to earlier, if there isn't enough liver function left, we really can't do these things because we can do more harm than good. If a patient has only a few months left, you don't want to cut that short. If they have portal vein occlusion, that may be important in certain scenarios and may narrow down the choices to really one, but we can debate about that. And of course, these two go hand in hand. Liver function and performance status of the patient, whether they're up and about more than 50% of the time during the day, they kind of correlate together. Again, if you have somebody who has very little reserve function left, you don't want to knock them out and potentially hurt them in that way. So when you look at these factors, is there any one that really stands out? They looked at this in 320 patients. They basically came out and said, really, you can look at the bar down here. No one factor was more statistically significant, but as you can guess, liver involvement was the one that came closest to it, right? If you have a patient who has more than half of their liver replaced by tumor, they're probably further along in the disease or have a more aggressive tumor type, so they're probably not going to do as well with treatment either. When you look at median overall survival, how long patients live afterwards, again, just like neuroendocrine tumors are good in the sense that patients live a long time with them, but as you can guess, patients who have less aggressive tumors live longer when you treat them. And the amount of complications is few and far in between. The biggest ones are maybe bleeding from the access site, liver abscesses, getting cholecystitis. PEs, renal failure, and arterial dissection are extremely rare, way less than 1%. Cholecystitis is also maybe 1 or 2%. Liver abscesses, as long as they haven't had their bile ducts messed around with, is also less than 1 or 2%. If they have had surgery before, they've had their biliary anatomy compromised, the risk of liver infections goes up, and that's another factor that may induce us to use one of the treatments, radioembolization, more than the other. So what do our results look like? When you do just embolization for patients, you get a survival range that's really great, and objective tumor response of 50%, about half the patients respond or more. That's patients actually having their tumor shrink. If you count patients whose tumor stays the same size, the number is actually much higher. That here is a little bit overestimated, and they have some related post-embolization syndrome, which we expect to see from people. But again, these are very mild usually, but about 3/4 of the patients have symptoms of having low-grade temperatures, pain obviously in their liver, and having some nausea or vomiting after the procedures. As opposed to ablation, where we get to send patients home the same day frequently, when we do the embolizations, except for radioembolization, most patients have to stay overnight. And I tell the patients, you have to be able to eat without throwing up, walking around, and your pain control before we can send you home. Having said that, most patients are home the next day, even from embolization. And after a couple of weeks, maybe 3-4 weeks at most, they're back to their baseline level of activity. Let me just skip this because we covered this stuff. What do these look like afterwards? So here's some examples of a crania towards the head MRI in a patient that has these tumors in their liver, neuroendocrine tumors. When you scroll the pictures down and see further down towards their foot, you see additional tumors. So this is a patient you really can't debulk, but we want to go ahead and embolize. And once you embolize them, you see that the tumors have shrunk significantly. So if you look at the pre and post pictures, there is significantly decreased tumor burden in the patient. There's another picture of the same thing. All right, what about chemoembolization? There are two categories of chemoembolization. For the past 30 years, 40 years or more, we've done conventional chemoembolization to treat all sorts of tumors within the liver. This was injecting chemotherapeutic agents with Lipiodol and then putting some embolic agent, the same bland embolics we talked previously, right afterwards. More recently, in the past decade or so, we've been treating tumors with drug-eluting beads, which basically, if you want to think of an analogy, like having beads be little sponges that hold chemotherapy and release it much more slowly. The thought process here is that chemotherapy only affects cells at certain part of their cycles. A lot of them do, and if you release them over a longer period of time, you're more likely to hit the tumor at the right time and also decrease the amount of side effects the patients are getting from it. Unfortunately, when you compare the two of these guys together, there isn't really much difference in a lot of the tumors. And this benefit is the fact that the side effects are much milder with the drug-eluting beads. So what do we see when we do this? Again, you see the response rate, the partial response, stable disease, and progressive disease rates being really good. So stable disease with progressive partial response is about 95% in these patients. Time to progression was over a year. And patients who were symptomatic really responded really well to this therapy. Again, the survival curves, the statistics, the side effects, all are comparable to each other. And when you compare it to radioembolization, radioembolization does better as far as the side effects are concerned immediately. So, but as far as you will see later on, survival benefits is really limited advantage. So when you look at the efficacy for radioembolization, that's what Y90 radioembolization for neuroendocrine tumors, you notice again that when you have the large meta-analysis of patients, of 414 patients, the response rate was about 50%, control rate was about 86%, very similar to everything else we've done. The patients' characteristics in this study were similar, and here's some pictures of, again, patients having radioembolization. With radioembolization, it becomes a little bit harder to read afterwards because the pictures look a little bit different on follow-up, but again, you see shrinkage of tumors and really good response rates, very similar to both chemoembolization and bland embolization. So that becomes the question is like, so which one is really better for my tumor that I have in my abdomen or my patient has in their belly? Well, there's one really good study that looked at these in across 155 patients. Fairly equal spread between these guys, showed that progression-free survival within the liver was about a year, overall survival was about 4 years. And again, they split it up by how fast the tumors were going, showing that if you have a higher grade tumor, you may, unfortunately, obviously, the progression ends up being faster and survival ends up being worse. But the most important slide here was, is there any difference between these different kinds of therapy, whether it be chemoembolization, radioembolization, or bland embolization? And they saw really no, there's not that much difference between these different modalities. So when the question becomes, what do you use for these patients? And we have a slide further down the presentation to say what the NCCN has said about this. My go-to for these guys is small bland embolization, because even though the side effects might be a little bit harsher than radioembolization, you don't get any added additional survival benefit from radioembolization. Sure, you go home the same day, but down the road, and patients may have higher incidence of liver failure, which we'll get to in a few minutes. You don't want that to happen. You want to save the patient's liver functions for all the additional chemotherapeutic agents that are options that are available, or some trials. So you don't want to have a patient who's living with, God forbid, liver failure from the treatment that you gave them. Having said that, if a patient has like bile duct inadequacy, or that makes him more prone to getting infections, that may be a situation where you want to use radioembolization more frequently. just to touch on some advances we have for embolization, if you have 1 or 2 tumors, you can actually use special software to trace out the blood vessels that go to it, thereby limiting how much collateral damage you get even from radioembolization. What I was alluding to before is that for a few years now, we've been following patients with radioembolization, and we've noticed not just for neuroendocrine tumors, but also for other tumors, yeah, we treat the tumors, they respond really well, but maybe 4 or 5 years down the road, whether it be a cumulative effect of the radioembolization plus the systemic therapy that also taxes the liver, patients are having liver failure afterwards. So it's sometimes hard to figure out what's causing what, because patients who have tumors in their liver, who are getting systemic therapy, who are getting embolizations, are getting a lot of damage to their liver. So you don't know what's causing liver failure, but it's certainly, if you can avoid a potential cause for liver failure, would like to avoid it as much as possible. So what about when we have this great treatment for doing the peptide receptor radiokinetic therapy? Does it matter if you've gotten it before, if you're going to do radioembolization or even bland embolization? The answer is really it doesn't seem to make much difference as far as causing liver failure for patients. When you look at the adverse effects and survival, etc., you really don't see any extra side effects from it or liver failures from it because of having received radiation type therapy beforehand. Similarly, if you go the other way around, what about if you have received intraarterial therapy before, and do you lose any effectiveness from the PRRT? And the answer to that has been similarly no, and the amount of side effects have been similar whether you've had it before or not. And actually, I mean, this is not statistically significant. If you look at people who've had treatment to their liver previously versus people who haven't had treatment previously, the people who've had treatment to the liver had overall done better compared to people who don't. Again, this is for statistical purposes, they're basically the same response rate, but as we can for certain say sure that there is no bad effects from having local regional therapy if you're going to get PRRT afterwards. So do I know which way to go on this? No, not really, but that's something that needs to be addressed later. I'm going to skip over the things we do to help the surgeons cut out more tumors. I think it's not as important part of a talk here. Suffice it to say, there are things we can do to the liver to make it get bigger so that the surgeons can be more aggressive with cutting out the tumors within the patient's liver. Again, as Dr. Liu said, if we can get as much disease out of the patient as possible, whether it be percutaneous, surgical, or both, that is something we should really aim for. This is a slide that shows how we occlude the portal vein and the hepatic vein sometimes to try to make the liver get bigger, and it works really well to enable the patient to get liver resection. So here's an example of this is glue or MBCA in the portal vein, and this is a plug being deployed in the hepatic vein, all to make sure that we can hypertrophy the left lobe of the liver as much as possible, as you can see on these slides. Okay, let's go back to our talk here. And what about the NCCN we all refer to a lot? But what's new this year is that they basically revised the recommendations to make ablation a little bit more favorable, and saying that we can do the pneumo dissections to get more lesions. Also, the fact that radioembolization was taken off being on par with the other chemoembolization and bland embolization, but they expressed their concern about bilobal radioembolization. This is because of the risk of liver failure. Having said that, they also emphasized the fact that if you have biliary incompetence, you might want to go with radioembolization because of the fact that the risk of liver abscesses is much lower than if you do it with bland embolization or chemoembolization. So it still has a role, but we'd really like to stick with bland embolization if possible. There's some areas of investigation. that we need to figure out. Again, as I mentioned with with regards to PRRT, does it really matter which way we go? How can we fit everything together better? The short answer is just as we've alluded to, you want to really seek out experts who work together to come up with the best plan for the patient. And it's really hard to find centers that have good people in every field, but it's worth seeking them out and getting a consult from the people and all people involved. I think we have time for so the answer to this, we already saw that there's really none of the above, but if you're going to pick one, my favorite is bland embolization for treating liver dominant disease. Okay. All right, very good. Any questions?
Great, thank you, Emil. Thanks a lot. So let's see. So there's, I think that we still have that one question. So if you have, I think you've touched upon that a little bit in your presentation. So the question was, what kind of treatment is appropriate for each grade tumor? So again, of course, low grade versus high grade.
I think that if, as far as like interventional radiology is concerned, really the grade of tumor doesn't matter as much to us as it does for surgery or chemotherapy. So I rely on my colleagues in the oncology to really, and talking with them to guide us which one to do. I certainly want to move faster on a higher grade tumors to try to get at them faster, basically.
Yeah, that's great. Yeah, and usually, again, as I was showing about the impact of imaging on the characterization of biology of the tumor, certainly, I guess you would agree that the ones that characterize a higher grade, more aggressive, are the ones that probably, of course, would be the ones to be targeted definitely with the liver-directed treatments rather than obviously.
Yeah, PRT, no, like you've said many times, again, seeing all the lesions and how aggressive they are is extremely important, and it's very great having those additional tools to see as much of the disease as possible before we get in, especially with nuclear medicine techniques.
All right, so great. Thank you so much, Dr. Cohen. That was great. We are a few minutes, like 4 or 5 minutes ahead of time. So I think we can maybe have some time at the end for some additional questions if there are. So next, I would like to introduce Dr. Jonathan Strasberg, who will be presenting on systemic treatments in neuroendocrine tumor and trying to put everything together. Hi, Jonathan, how are you? Thank you again so much for being part of this. It's always great to have you. It's not 7 o'clock in the morning for you, or I was with Eric, but great to have you. So I'd like to spend just a few words on Dr. Strasberg. Dr. Strasberg is a professor at the Moffitt Cancer Center in Tampa, in Florida. He specializes in management of neuroendocrine malignancies. He graduated at Harvard and then Cornell Medical College, and he's completed his residency and fellowship at the Georgetown University Hospital and the Moffitt Cancer Center. He leads the Moffitt's neuroendocrine tumor division in the Department of Gastrointestinal Oncology Research Program. He has published over 150 articles on the diagnosis and management specifically of neuroendocrine malignancies. He is first author in publications in New England Journal of Medicine, Journal of Clinical Oncology, Annals of Oncology, Clinical Cancer Research, and other major journals. So it's a very important journals, of course. He is a recipient of the National Cancer Institute's Clinical Investigator Team Leadership Award. And he also serves on the board of directors of the North American Neuroendocrine Tumor Society, NANETS, on the Neuroendocrine Guidelines Committee for the National Comprehensive Cancer Network, so the NCCN guidelines, which have been cited several times in this session, and in the Neuroendocrine Task Force of the National Cancer Institute. So again, it's a great privilege and honor and a pleasure to have you with us, Dr. Strasberg. Thank you.
Great, thanks. I really appreciate the invitation. So I'm going to be focusing on systemic treatments for neuroendocrine tumors, well-differentiated gastroenteropancreatic neuroendocrine tumors to be specific. These are my disclosures. And I think it's always helpful to start with a case that sort of brings this all together, the multidisciplinary management of these tumors. So this patient presented in 2009. He was 47 years old at the time with intermittent abdominal pain, some heartburn, night sweats. Was found to have a large tumor in the pancreatic tail, retroperitoneal adenopathy, and several hypervascular lesions in the left liver. Liver biopsy revealed well-differentiated low-grade neuroendocrine tumor. We did an octria scan at the time that showed somatostatin receptor uptake. And so these are some of the options that we were considering at the time. Surgical debulking, as Eric described so well, potentially preoperative treatment followed by surgical debulking, and then any number of systemic treatments. He was started on octreotide, had stable disease. Surgery was recommended in multidisciplinary tumor board, but the feeling was that it would be easier if there was a little bit of cytoreduction first. We tried chemotherapy with capecitabine temozolomide, which yielded a minor response. The surgeon wanted the primary tumor to be a bit smaller, and so we administered chemoradiation to the distal pancreas as well as retroperitoneal lymph nodes. And eventually, the patient underwent distal pancreatectomy, lymph node dissection, and wedge resection of liver tumors, as well as radiofrequency ablations. He was maintained on octreotide, had stable disease for 5 years. In 2015, had a little bit of growth of remaining liver tumors. Again, there were multiple options discussed, ranging from surgery to liver embolization to various systemic options. He decided he didn't want to undergo surgery. He underwent bland embolization instead. He progressed both in and outside of the liver 2 years later, began everolimus, progressed a year later. At the time, we repeated somatostatin receptor imaging. This time was the gallium-68 dotatate scan, which showed strong somatostatin receptor expression, and he received 4 cycles of peptide receptor radiotherapy with lutetium dotatate. And he actually responded quite well. He remained in remission for over 3 years, but is now actually starting to progress as of last week, just in one tumor in the liver. And so it's back to tumor board to discuss perhaps more liver-directed therapy. So just a case that really integrates all the different multidisciplinary approaches to management of these tumors. And I certainly the outcome with lutetium dotatate in this case is a bit above average, given that it's about the 5th or 6th line of treatment, but still illustrative of this particular therapy and potential outcomes. So systemic treatments typically start with somatostatin analogs when we're dealing with well-differentiated somatostatin receptor expressing neuroendocrine tumors, particularly if they're low or intermediate grade, not so much for high grade. The 2 commercially available somatostatin analogs in this disease are octreotide and lanreotide. They're both analogs of the human hormone somatostatin with a long half-life. The initial data on somatostatin analogs was for control of hormonal syndromes associated with neuroendocrine tumors, such as the carcinoid syndrome, which is associated with flushing, diarrhea, and in some cases, carcinoid heart disease. And what was shown is that octreotide could palliate symptoms in the majority of cases, in other words, reduce incidence of diarrhea and flushing, and reduce levels of serotonin, measured typically as the metabolite in the urine 5-HIAA. So about 3 out of 4 patients had very significant symptom improvements and significant reductions in urine 5-HIAA. Interestingly, it wasn't until several years later that it became apparent that these drugs can also control tumor growth. The first phase 3 drug trial to prove this was the PROMID study, in which patients with small bowel midgut nets were randomized to receive octreotide LAR versus placebo. And despite a very low response rate of only 1%, there was a very significant rate of disease stabilization and improvement in median time to progression from 6 months on placebo to over 14 months with octreotide. Subsequently, the Clarinet study looked at lanreotide every 4 weeks versus placebo in enteropancreatic neuroendocrine tumors with Ki67 less than 10%. So low grade and sort of low intermediate, all expressing somatostatin receptors on octrea scan. Again, the primary endpoint was progression-free survival, and there was a significant improvement in PFS. The hazard ratio was 0.47. The median PFS on placebo was 18 months, so this was a relatively slow-growing population of patients. It was not reached at the time of primary analysis with lanreotide. Later, with open label extension, the median PFS was approximately 3 years with lanreotide. Somatostatin analogs are exceptionally well tolerated, very low risk. We have high level of evidence to support their use, and they work in patients with functional tumor symptoms, not just carcinoid syndrome, but also other hormonal syndromes such as VIPomas, glucogenomas, gastrinomas to some extent. We shouldn't expect radiographic response with these drugs. They almost always result in disease stabilization as best response. And the evidence supporting their use is primarily in patients with low or low intermediate grade tumors. There are some side effects, as Eric mentioned. They can lead to gallstones in the long run. They can lead to steatorrhea, which we typically manage with pancreatic enzymes such as creon. Sometimes a little bit of nausea and bloating, especially with the first injection, but generally very well tolerated. Another drug that we use is everolimus. Everolimus is an mTOR inhibitor. mTOR is a very central enzyme that contributes to cancer progression. About 15% of pancreatic NETs have discrete mutations in the mTOR pathway, but we know that the pathway is upregulated even in the absence of specific mutations. There were 3 large randomized phase 3 studies looking at everolimus in this population of patients. The first was RADIANT-2, which looked at everolimus plus octreotide versus placebo plus octreotide in patients with progressive metastatic neuroendocrine tumors and history of carcinoid syndrome. So mostly midgut neuroendocrine tumors. Those are the tumors primarily associated with carcinoid syndrome. And there was a marginal improvement in progression-free survival, just borderline not statistically significant. RADIANT-3 looked at everolimus versus placebo in pancreatic neuroendocrine tumors, progressive pancreatic neuroendocrine tumors. This study showed a much more robust benefit. The hazard ratio was 0.35. This was very statistically significant. Median PFS increased from about 4.5 months with placebo to 11 months with everolimus. And then RADIANT-4 looked at the last piece of the puzzle, non-functional, in other words, non-hormone producing gastrointestinal and lung nets, so lung, gastroduodenal, colorectal, not so many midgut. Everolimus versus placebo, no octreotide, no somatostatin analog, no crossover either. And this again showed a significant improvement in PFS from about 3.5 months to nearly a year, and also very statistically significant. With respect to overall survival, the RADIANT-2 study, which was not statistically significant for progression, actually showed numerically lower overall survival with everolimus, suggesting that for the average typical midgut patient with carcinoid syndrome, this drug may not be the best. RADIANT-3 showed a small trend towards improved overall survival, but let's remember there was crossover in the study, so it wasn't really powered for overall survival. And RADIANT-4 also showed a trend towards overall survival benefit. But again, all these studies are powered for PFS. Everolimus can cause side effects, including canker sores in the mouth, hyperglycemia, diarrhea, pneumonitis in some cases. It's an immunosuppressant, so there's increased risk of infection. So certainly some side effects that can impact patient quality of life, and therefore we need to be judicious in its use for patients who have real disease progression. So we have strong evidence for use in progressive pancreatic nets and other primarily non-midgut, non-functional nets, relatively weak evidence for use in your typical midgut net with carcinoid syndrome. Again, we need to select patients with clinically significant disease progression. Another drug that's active in neuroendocrine tumors is sunitinib. Neuroendocrine tumors are highly vascular. Sunitinib targets the VEGF receptor, which contributes to the blood vessel growth of tumor, as well as other tyrosine kinase receptors. So in pancreatic neuroendocrine tumors, a phase 3 study demonstrated a significant improvement in progression-free survival with sunitinib versus placebo, virtually identical to the RADIANT-3 study, which showed pretty much the same improvement with everolimus versus placebo. So very similar data with sunitinib compared to everolimus in pancreatic NETs. Sunitinib has different range of adverse events. I wouldn't necessarily say it's more or less severe than everolimus. It's just different. There's more perhaps fatigue, hypertension, diarrhea, cytopenias. Many patients develop painful rash on the hands and feet, so-called hand-foot syndrome. And there is a slight increase in cardiovascular events. So we can choose between sunitinib versus everolimus in pancreatic NETs based on comorbidities and side effect profile. Alkylating agent chemotherapy is primarily been looked at in pancreatic neuroendocrine tumors. That's where it seems to be most effective. In the past, we used streptozotocin. In the last decade, it's been mostly temozolomide, which is an oral alkylating agent, and primarily in combination with capecitabine. And we've seen response rates at high 70% with this regimen in progressive pancreatic NETs. This led to the ECOG 2211 study, in which patients were randomized to receive either capecitabine temozolomide or temozolomide monotherapy with progressive pancreatic NETs. Primary endpoint was progression-free survival. The study met its endpoint. The median PFS with CAPTEM was nearly 2 years, substantially higher, I should to what we see with sunitinib or everolimus. And there also was an overall survival benefit, although I have to, acknowledge it was a randomized phase 2 study, not a phase 3 study, and so there's a higher likelihood of false positive findings. Capecitabine temozolomide is well tolerated in general. About 10% of patients can develop grade 4 cytopenias, usually we notice this in the first cycle, and it's often delayed. So it's very important when you check your blood levels to do it right before starting each cycle. In other words, every 4 weeks. If the counts start going down, hold treatment, keep on following until they recover. So if you come at week 4 and the platelet count is 90, keep on monitoring closely. It could get quite low. Again, I usually see this with the first cycle. Another important thing to mention is with temozolomide, you really need to give antiemetic before temozolomide, typically Zofran on ondansetron, 8 milligrams, 30 to 60 minutes before. If you don't, the patient will get very sick. If you do, nausea rates are quite low. So something important to remember when prescribing oral chemotherapy. You have to prescribe proper antiemetics, just as we do with intravenous, where the antiemetics are part of the template we order. So strengths, high response rates in pancreatic NETs, approximately 50%, well tolerated if prescribed properly. Oral administration in pancreatic NETs, we have evidence of improvement in PFS as well as OS in a randomized phase 2 study. Main weakness is the unpredictable cytopenias. So particularly appropriate for patients with pancreatic NETs, aggressive disease, high tumor burden, or tumor-related symptoms. There are smaller retrospective series showing efficacy in non-pancreatic NETs, particularly foregut, like lung. Not so much evidence in midgut unless they're high grade. Moving on to peptide receptor radiotherapy. This therapy has been around for a few decades, but approved in the United States and Europe since 2018. And the isotope approved is lutetium-177, which is a beta-emitting isotope. The principle is that when you combine an isotope to a somatostatin analog, you can target somatostatin receptor expressing tumors. And most well-differentiated neuroendocrine tumors express high levels of somatostatin analogs. Much of the data has come from Erasmus University in the Netherlands. At the time this large series was published, they had treated over 1,200 patients. The focus of this analysis was on patients with gastroenteropancreatic and lung NETs who were treated in the Netherlands, in other words, Dutch national patients who were available both for treatment and for long-term follow-up. And in total, there were about 600 patients, of which 443 had completed at least 3 treatments and were therefore eligible for efficacy analysis. The treatment consists of 4 cycles of lutetium dotatate at a fixed dose, 200 millicuries every 8 weeks, so a total of 6 months duration of treatment. And when they looked at the patients who had received these 3 treatments, the response rates were approximately 30 to 50%, 30% in midgut nets, approximately 50% in pancreatic nets. Median progression survival ranged from about 2.5 to 3 years, perhaps a little bit lower in lung nets. Again, this was not a true intention to treat analysis. We have to take that in mind. There were about 15% of patients who had not completed all 3 or 4 cycles. In addition to short-term cytopenias, this treatment is associated with a long-term risk of myelodysplastic syndrome or leukemia of approximately 2 to 3%. In the past, we thought that there was a certain rate of nephrotoxicity associated with this. It seems to be fairly negligible. Hepatotoxicity is also quite negligible unless patients have been heavily pretreated in the liver or have a very, very large tumor burden. Not surprisingly, somatostatin receptor imaging predicts response because this is a somatostatin receptor targeted treatment. On Octria scans, you wanted to see uptake at least equivalent to the normal liver in order for patients to be eligible. With the newer dotatate PETs, you really want to see uptake higher than the normal liver, and some studies have shown that uptake double the normal liver is predictive of response. So the more uptake, the more likelihood our patients are to benefit from treatment. The NETTER-1 study was a randomized phase 3 study evaluating lutetium dotatate in patients with progressive midgut neuroendocrine tumors, in other words, small bowel and cecum. They had to have progressed on octreotide LAR. They were randomized to lutetium dotatate 4 cycles, exactly as I described before, versus high-dose octreotide 60 milligrams every 4 weeks, with the primary endpoint of progression-free survival. The study met its primary endpoint with an 80% improvement in PFS. The median PFS on high-dose octreotide was 8 months. It had not been reached with lutetium dotatate at the time of primary analysis. The objective response rate was 18% with lutetium versus 3% with octreotide. This was also statistically significant. And the initial analysis of overall survival at the time of the primary endpoint analysis showed nearly twice as many deaths with octreotide versus lutetium, hazard ratio of 0.4. 5 years after last patient was randomized was the pre-specified time for final analysis. It was either that or 142 death events observed. However, at the 5-year cutoff point, there were fewer than 142 deaths, and therefore the 5-year time point triggered analysis of overall survival. There was a fairly long follow-up, median follow-up at the time on both arms. And this just published actually a few days ago, the final overall survival data showing an improvement of about 12 months in median overall survival. The hazard ratio was 0.84. This was not statistically significant, but important to emphasize the study was powered for PFS, not for overall survival with crossover. And indeed, at least 36% of patients crossed over eventually to receive peptide receptor radiotherapy, in almost all cases lutetium dotatate, after the drug was approved. If we use statistical methodology to control for crossover, the improvement in PFS increases to 18 months and the hazard ratio increases to 0.73. In total, there were 2 cases of myelodysplastic syndrome on the lutetium arm, so a little less than 2%, really consistent with what we've seen in the Rotterdam data and other large databases. And when we look at change in creatinine clearance in both arms of the study, there's absolutely no difference. It's virtually identical. So no real evidence of nephrotoxicity when lutetium is administered with prophylactic amino acids, as it should be. So the pre-specified final analysis of overall survival showed I'd say a clinically meaningful 12-month improvement in overall survival, not statistically significant, but again, not powered really for overall survival analysis with crossover, and no new safety signals. I do want to highlight some potential concerns with PRRT. Patients with mesenteric tumors, these tumors consist, to a large extent of fibrous tissue. These tumors do not respond to PRRT, and there's some concerns that it can actually increase desmoplasia. Patients with excessive peritoneal disease, we now have evidence suggesting that they may develop radiation peritonitis, and this can lead to particularly severe bowel obstruction, frozen abdomen. You want to be very careful when patients with high peritoneal burden and probably not treat. In cases with moderate peritoneal burden of disease, we administer prophylactic steroids, which seem to be effective both at palliating as well as preventing this complication. As Giuseppe also already mentioned, you really need to look carefully at the scans before administering PRRT to make sure that all the tumors express somatostatin receptors. This is particularly a concern in higher grade neuroendocrine tumors and lung neuroendocrine tumors, sometimes pancreatic neuroendocrine tumors, where the expression can be heterogeneous, not so much in midgut nets. High grade disease, there's not much data. The data that does exist suggests that it's patients with really borderline high grade disease, Ki67, 20, 30, 40%, not higher than that stand to benefit from PRRT. So this does not work in very aggressive tumors. Even though liver toxicity is not usually an issue, there is some data suggesting that patients who have been heavily pretreated may not do that well with PRRT, especially if they've already have evidence of liver damage, for example, with radioembolization, and then you administer additional radiation in the form of PRRT that can lead to liver dysfunction. In the past, the drug was administered only in patients with really intact renal function. We have evidence from the NETTER-1 study that patients with moderate renal function, creatinine clearance as low as 30, can be treated without increase of nephrotoxicity or other toxicities. There's little data in patients with creatinine clearance below 30. It is important, though, to ensure that the renal outflow is appropriate. So if they have hydronephrosis, for example, that could increase risk of renal toxicity. So when we look at the entire treatment landscape, in midgut neuroendocrine tumors that are metastatic, surgically unresectable, we typically start with a somatostatin analog. When they progress, options include lutetium dotatate, especially if the tumors are widely metastatic and express somatostatin receptors. Hepatic arterial embolization is certainly an option in liver-dominant disease. Everolimus, not so much based on the RADIANT-2 study, but we can consider it in certain cases, especially if patients are poor candidates for the other treatments. For non-midgut GI and lung nets, if they're somatostatin receptor positive, again, we typically start with an SSA. Otherwise, in no particular order, there's everolimus based on the RADIANT-4 study. There's evidence for PRRT, and it's approved for this indication, and although the NETTER-1 study was only midgut nets. Hepatic arterial embolization if they're liver dominant, and there's some evidence to support use of capecitabine temozolomide, particularly in foregut nets. And then finally, for pancreatic neuroendocrine tumors, if they're somatostatin receptor positive, also often start with somatostatin analog. And again, in no particular order, there's everolimus based on radiant-3, there's sunitinib, CAPTEM is highly active with a high response rate, PRRT also associated with high response rate, and we tend to use liver embolization less frequently in this disease. There's not much data, unfortunately, on how to best sequence these treatments. Briefly want to touch on novel drugs. There's phase 2 data looking at lenvatinib, which is a tyrosine kinase inhibitor, evaluating vascular endothelial growth factor as well as fibroblast growth factor receptor. Particularly high rates in pancreatic NETs, 44% is higher than what we've seen with any other targeted agent, where the response rates are typically in the 10% range. Response rates lower in GI NETs. The median PFS, though, was a little bit longer. Fortunately, I don't think we're going to see phase 3 studies with this drug. Cabozantinib has shown promising activity in phase 2 trial, and currently the Alliance is running a randomized phase 3 study of cabozantinib versus placebo in GI lung NETs as well as pancreatic NETs, 2 large cohorts. I think there was a slide that somehow got dropped, but surufatinib is another tyrosine kinase inhibitor. It targets the VEGF receptor among several others. 2 phase 3 studies in China showed improved PFS in pancreatic NETs as well as GI lung and thymic NETs. And so it may be approved in the United States in 2022 based on these data from China, as well as a small phase 2 study in the United States. So surufatinib, another drug that, another tyrosine kinase inhibitor that we're anticipating approval in the United States in the near future. With respect to new PRRT drugs, we're anticipating studies with alpha-emitting PRRT. One drug is lead-212 dotamtate. Alpha emitters basically are completely different from lutetium, which is a beta emitter. Beta emitters emit electrons. Alpha emitters emit much, much larger particles, basically helium nuclei, 2 protons, 2 neutrons, so much larger particles, higher energy, much shorter particle range, potentially resulting in double-strand DNA damage. The results from this phase 1 study of lead dotamtate were really quite impressive. There was also a study from India, a retrospective series looking at actinium dotamtate in PRRT refractory patients, also quite impressive. And I'll stop here. Thank you very much.
Great, thank you so much, Jonathan. That was great and a great overview. Again, putting everything together. So we do have a few minutes left. So again, I think there's still one question from the audience, and the question again is, what kind of treatment is appropriate for each grade tumor? So I don't know, Jonathan, if you want to add anything to that question.
Yeah, so let me just start at both because of the topic and the time. I did not mention poorly differentiated neuroendocrine carcinomas. These are completely different cancers. They share features with well-differentiated neuroendocrine tumors, but morphologically different, and they're extremely aggressive. They're typically treated with platinum etoposide chemotherapy. There's some data that immunotherapy might work as a second-line treatment, particularly with combination ipi-nivo, but none of the drugs that we talked about today is active in poorly differentiated neuroendocrine carcinomas, and liver-directed therapies as well as surgery are rarely used either. So putting that aside, when we're talking about well-differentiated neuroendocrine tumors, we have 3 grades: low, intermediate, and high. So you can get well-differentiated to high grade. And that does influence our treatment choices. So most of the treatments that we're talking about have been studied in low and intermediate grade tumors, meaning Ki67 less than 20%. They haven't been studied well in high grade tumors. The exception is chemotherapy, for example, capecitabine temozolomide. There is data in well-differentiated high grade tumors. In fact, some data suggest that the optimal Ki67 for response is somewhere in the 10 to 40% range. So if you have a higher grade tumor, you might want to think more about cytotoxic chemotherapy, such as CAPTEM. In fact, midgut tumors, we recently presented some data. CAPTEM really has no radiographic response rate in low intermediate tumors, but does have some response in high-grade tumors. So we're more likely to consider cytotoxic chemotherapy, including CAPTEM and even platinum-based chemotherapy in well-differentiated high-grade tumors. Somatostatin analogs, the data is primarily in low-grade tumor or low intermediate. There is some evidence of activity in higher grade tumors if they express somatostatin receptors, but the progression-free survival is quite short. So somatostatin analogs are sort of the opposite of cytotoxic chemotherapy. You want to think about them more in the least aggressive tumors. When it comes to liver embolization, we tend to use it in less aggressive tumors. It doesn't seem to work that well for aggressive tumors. My experience is that I tend not to use radioembolization in low-grade tumors, particularly if they're bilobar, for the reasons that Dr. Cohen mentioned, long-term liver toxicity. But if a patient has a highish grade tumor that's fairly aggressive, we've seen better responses with radioembolization compared to bland embolization. So that would be one scenario where we would consider radioembolization.
Well, great. Thank you so much. And again, thank you for the wonderful presentation. So we are right on time. So I don't think I see any additional questions from the audience. So again, I'd like to thank all of you, Dr. Liu, Dr. Cohen.
Giuseppe, can I ask a favor?
Hey, yes.
I think the team has figured out a way for me to show the videos. If the audience is interested, I'd love to show those videos because they're very interesting for the surgical techniques.
Okay, sure.
Michael, can you switch it over? Great, thanks. I just want to show you, this is a technology that we've started to utilize where we can actually look at blood flow during the operation. I know it looks very, very black here, but basically I have put clamps around the tumor to cut off the blood supply. And then when you inject the medicine, you can see if it seemed to go much faster in the operating room. It's a little slower here. I don't know what's going on. But you can see it's totally worth it. I promise you, it's worth the wait. Because the video works.
You should have done it in the form of a TikTok.
Yeah, that's right. I get 30 seconds to show it. Now I'm dancing in the background, so that's really what. Here it comes. So you can see here, as the blood flows, it brings this fluorescent agent, and so I can see where healthy bowel is and where unhealthy bowel is. So you can see that big clamp there, which cuts off blood supply, and you can see that bowel is black, and so that's the bowel that I'm going to remove. And the one that glows is very healthy and very strong. So that's how I do the surgery carefully to know that we are removing the right portions. And it allows me to get much, much more tumor because I can very carefully and easily determine what is normal, what will survive, and what will not. So you can see it there. You can even see just kind of by eye how a little bit purple it is. But with this technology, it makes it so much clearer to me that I can do the operation safely. You see that big tumor right in the middle of that white thing in the middle? So that allows me to pick that thing out while preserving intestines. So this is a very, very nice technology we've implemented recently.
Wow, this is very, very nice. And again, what do you inject, Eric?
It's indigo cyanin green, so ICG. And what it does is it flows with the blood. And then I can just watch it flow into the blood, and it tells me. We had some older techniques, maybe just looking at it visually, which is, we know it's just not good enough. Sometimes we would use something called a Doppler, where you could hold actually a little probe and listen to the blood flow, which was not very reliable. This is essentially 100% reliable. And so it allows us to do things which, let's just say traditional general surgeons would be a little bit more nervous and leery to do. So it lets us get those tumors that are deeper inside of the bowels.
Great.